Welcome back to point-of-care musculoskeletal ultrasound for bleed detection in joints and muscles. This is part 3 and will address muscle bleeds, but also how to distinguish hip and iliopsoas bleeds. My name is Annette von Dregalski. I'm an associate clinical professor of medicine and the director of the Hemophilia and Thrombosis Treatment Center at the University of California, San Diego. The following abbreviations may be used in the module: POC for point of care and MUSCUS for musculoskeletal ultrasound. First, we will discuss the general appearance of muscle bleeds, followed by the distinction of hip from iliopsoas bleeding. Let us start with muscle bleeds, but before doing so, provide a simple depiction of muscle structure. Muscles are composed of many fascicles that are separated from each other by sheath. Fascicles are composed of single muscle fibers, which in turn are composed of many myofibrils as the smallest unit. Bleeding can occur in any part of the muscle, and blood can travel between fibers and sheath. Muscles are organized in compartments, and extensive blood volume and limited space may result in compartment syndrome, which results in compression of nerves, vessels, and other structures. The appearance of muscle bleeds will be presented in a case series depicting 3 different cases. We start with a quadriceps bleed in a patient with mild hemophilia A who ran into an object in the garage. Here in the schematic, you see in blue the transducer position in longitudinal axis to view the hematoma. The bottom panel on the left shows the normal femur unaffected with a white, bright, bony femoral line and muscle structure on top, regular in nature. You can see the muscle fibers here separated by a sheath. In contrast, the panel on the top left here shows the right thigh muscle bleed with a completely distorted fiber structure of the muscle with hyperechoic and hypoechoic areas, mixed echogenicity, and a cranial displacement of the sheath. The ultrasound permits 2-dimensional measurements of hematomas, and you can see here that this hematoma measures 3.67 times 7.63 centimeters. The ultrasound permits to follow the resolution of hematomas over time, which is exemplified here in a time course from top to bottom, imaging at 2 days, at 2 weeks, and at 2 months. And as you can see, there is shrinkage of the hematoma, but even at 2 months, the hematoma is still 3.6 times 1.3 centimeters, demonstrating that bleed resolution can take weeks to months. Please also note that although these 2 images look almost as if this hematoma was larger than this one, both images are taken at a different depth and zoom, and this explains the almost similar appearance. However, when measured, this is clearly smaller than this. Case 2 is a hamstring bleed imaged in long axis, also in a patient with mild hemophilia A after slip landing in a split. 3 images are shown, the initial imaging at 6 weeks and 1 year later. In the initial imaging, you can see a large hematoma, 13 times 3.5 centimeters, possibly loculated, with mixed echogenicity areas in this area and hypoechoic to anechoic echoes in this area, possibly indicating fresh blood. At 6 weeks, the hematoma has somewhat shrunk and changed echogenicity characteristics, still irregular fibers and hyperechoic areas. And then even 1 year later, although the patient has become completely asymptomatic and the hematoma, I think, has disappeared, there is still a lesion present, 4 times 1.5 centimeters. This slide adds imaging in short axis when turning the transducer 90 degrees into short axis. And here you can again see the disruption of the muscle fibers and maybe even the loculated characteristics of this muscle bleed at 2 weeks after the initial occurrence, and then later at 6 weeks, still not very shrunken, again indicating how long it takes for hematomas to resolve. Case 3 shows a posterior calf bleed here with a compression movie. It also occurred in a patient with mild hemophilia A who experienced a pop in the calf while walking with a palpable painful knot in the posterior calf. This would be the area of the hematoma. Clearly visible are the disruptions of clear fiber structure. It almost looks like a figure 8. Here you see the measurements applied to the hematoma. It is important to notice that muscle hematomas are not always compressible, and this is probably due to tight muscle structure. This case of a posterior calf bleed was confirmed by CT imaging, and you can see here in axial, in coronal, and in sagittal dimension the bleed formation. This brings us to the end of our muscle bleed section, and the following teaching points are important. It can take a long time for muscle bleeds to resolve, even with prolonged clotting factor replacement. This is what we learned with the ultrasound through longitudinal follow-up. Muscle bleeds are heterogeneous in echo texture. They can be hypoechoic, hyperechoic, or of mixed echogenicity. Muscle bleeds can be measured in 2 dimensions, which allows follow-up over time. And if they are large, they may require a so-called extended view slide function on your ultrasound. Not every ultrasound has it. That allows sliding of the ultrasound in longitudinal or transverse axis and capturing the hematoma on one single image. We now proceed to distinguish hip from iliopsoas bleeding. Before doing so, let's review some anatomy of the hip joint and capsule. In this first schematic here, you see the articular surface of the femoral head resting in the acetabulum that is also covered by cartilage, here with the labrum, and surrounded by a fibrous joint capsule that anchors here at the larger trochanter, and this here would be the lesser trochanter. The iliopsoas muscle comes in 2 parts as the psoas major and iliacus muscle. The psoas major originates from the lower lumbar spine and the iliacus muscle from the acetabulum, combining into a iliopsoas tendon that inserts at the lesser trochanter. This schematic shows the hip capsule and iliopsoas muscle together. Again, the 2 bellies of the iliopsoas combining here in 1 tendon, and this has to be distinguished from the joint capsule here, and the joint capsule contains the intra-articular fluid. The joint capsule is a thick fibrous structure since it also contains intra-articular ligaments. If a hip effusion or bleed occurs or originates here from the joint space, it will accumulate within or underneath the capsule. Hip effusions should always be detectable by musculoskeletal ultrasound. On the other hand, iliopsoas bleeds can originate higher up in an area that is not accessible by the ultrasound beam. Hence, it can only be viewed if iliopsoas bleeds move down by gravity into the hip thigh area. Clinically, it is therefore important to understand that if a iliopsoas bleed cannot be picked up by ultrasound, it might sit high up and will require CT scanning. This schematic demonstrates the transducer probe position to image both iliopsoas bleeds and hip bleeds. First, align the reference end of the probe with the acetabulum and femoral head. Then align with the femoral shaft such that the probe points towards the trochanter slightly outward. This image shows the sonoanatomy of hip and iliopsoas muscle when the transducer position explained during the previous slide is applied. The structures visible can be described as follows. This is the acetabulum, followed by the femoral head, neck, and the femoral shaft. This area here comprises the joint capsule with intracapsular or intraarticular ligaments. Therefore, it will always have a sort of complex fibrous structure. And on top sits the iliopsoas tendon and muscle. I would like to point out that absent a hip effusion, the joint capsule follows very smoothly the contour of the femoral neck and the femoral shaft. During a hip effusion, the capsule is pushed upwards, and during an iliopsoas bleed, a hematoma would become visible in this area. Lastly, I would like to also mention that at the interface of the capsule and the iliopsoas tendon/muscle, a bursa can form, and this bursa can become fluid-filled. It's not visible right now in its natural form because not fluid-filled, but if fluid-filled, it has to be distinguished from a hip infusion or possibly an iliopsoas bleed. We begin with ultrasonography of iliopsoas muscle bleeds. This is now case 4 in our imaging series depicting an iliopsoas bleed in a patient with moderate hemophilia A who came to us after vigorous exercise with signs and symptoms of a femoral muscle bleed. So this depicts in schematic the transducer position as previously explained, anchoring the reference probe at the acetabulum, alignment with the femoral shaft pointing towards the greater trochanter. The ultrasound image in the left control, so in the uninjured leg, looks like this. Here visible is the femoral head, here a little bit visible is the acetabulum, and this would be the femoral shaft. Aligned with the femoral shaft is the hip capsule. Again, the hip capsule consists of intra-articular ligaments, and on top would be the iliopsoas muscle. Easily recognizable is the large iliopsoas bleed here in this patient on the right in his injured leg. Interestingly, or of note, the bleed is very large since the depth applied to this ultrasound image is not sufficient to pick up the femoral bone on the bottom. Use of the power Doppler function demonstrates new vascularization around the large hematoma. These are flash artifacts, but these are definitely positive power Doppler signals. Maybe it is imaginable how pseudotumors can originate from hematomas that are not properly treated. Case number 5 is another example of an iliopsoas bleed in a patient with severe hemophilia A and an inhibitor who experiences spontaneous pain in the iliopsoas or hip region. The longitudinal axis here with the transducer depicts the iliopsoas bleed as a hypoechoic disruption of fibers. Now again, going through the anatomy, here would be the femoral head, followed by the femoral shaft. The capsule is a mixed to hyperechoic structure following the femoral line, and here are remnants of the acetabulum. Iliopsoas bleeds can also be depicted in short axis or confirmed in short axis by swiveling the transducer around by 90 degrees in terms of providing a horizontal view here. And so underneath you can see now the hematoma as a hyperechoic disruption of fibers, here encircled with the circle function of the ultrasound machine. We will now proceed to hip effusions and work out the differences to iliopsoas bleeds. Let's proceed with a hip effusion in a case of severe hip osteoarthritis in a non-hemophilia subject. This is case 6, and you see here the radiograph depicting severe osteoarthritis in the left hip with some features of dysplasia, whereby the femoral head is not fully covered by the acetabulum. This slide shows the evaluation of the left and also the normal right hip with musculoskeletal ultrasound prior to hip replacement surgery. The same transducer position as for imaging iliopsoas bleeds is applied, and here you see the unaffected hip compared to the arthritic hip with the effusion. The structure here in the unaffected hip represents the femoral head. Here is the acetabulum, and this here is the fibrous capsule lining the femoral head. In the arthritic hip, you can also see the femoral head, an acetabulum tear, and a much wider capsule here containing not only fibrous intra-articular ligaments but also fluid. During surgery, the fluid was estimated to be 15 to 20 milliliters. Continued evaluation with Muscas shows even more of the effusion by sliding the transducer along the femoral shaft towards the trochanter. The unaffected right hip here shows the femoral head, the femoral shaft, which is lined by a fibrous but thin capsule, compared to the arthritic hip with the effusion, where the capsule is much extended and all of these contents represent an effusion. Please note the iliopsoas muscle on top here and here. An important teaching point to make here is that in the hip, it is not feasible to distinguish complex from simple effusions because of intracapsular ligaments that will always add complexity to the image. Now that we have learned what hip effusions look like, we will proceed to 2 examples showing hip bleeds in hemophilia patients. Case 7 is an elderly patient with severe hemophilia B who has also severe arthropathies in most joints, is on crutches, and experiences acute right hip pain. The panel to the left here shows the painful right hip joint. To the right here is the unaffected left hip that was positioned exactly as the right hip for imaging with the same degree of flexion. Now, as you now know, this would be the femoral head that is abnormal in this patient, and it is surrounded by a large complex effusion. Again, the complexity does not necessarily determine if it's bleeding or not in the hip, but in hemophilia right now, we just presume it is a hemathromatosis. Compare this to the unaffected left hip, the femoral head, a little bit of acetabulum, and the femoral shaft that is lined by a relatively unremarkable capsule. On top again is the iliopsoas muscle here and here on both sides. Additional ultrasound images sliding more towards the greater trochanter show again the large effusion in the painful right hip compared to the unaffected left hip, acetabulum, femur, and femoral shaft. The last patient of our case series is case number 8, also an elderly patient with severe hemophilia A. He is status post-fall 2 days prior to imaging on his replaced left hip. As in the other patient, we also imaged for comparison the unaffected right hip that was positioned exactly the same as the affected painful left hip. And you can see here the femoral condyle followed by the femoral shaft in alignment with the fibrous capsule. On top here is the iliopsoas muscle. It appears to have a normal fibrous pattern. Now contrast the image of the unaffected right hip with the image of the painful left hip. There are several findings that are noteworthy pointing out. First, you can appreciate an abnormal femoral head that is irregular, followed by the femoral shaft. The capsule is much distended, harboring a large effusion underneath, and the iliopsoas muscle does not appear to be normal. This area here seems to have interrupted fibrotexture with hyperechoic areas, and this area here is large and hyperechoic and not visible in the unaffected right hip, altogether pointing towards iliopsoas bleeding or hematoma in addition to the hip bleed. We would have liked to confirm muscle and/or joint bleeding in this patient with advanced MRI or CT scanning, but due to bad pains, the patient was unable to lie still in a specific position for prolonged periods of time. In many ways, this emphasizes the virtues of point-of-care ultrasound that can provide quite in-depth and quite informative imaging within minutes compared to complicated advanced imaging procedures. This concludes our module on joint and muscle bleed detection with point-of-care musculoskeletal ultrasound. I hope you found these modules informative and useful, as well as applicable to your clinical practice.